women are wanting to take control of their own health care. And by taking control of their own health care, they feel empowered. And I think it's a product also of some of the distrust that's present in the healthcare system in general, that we don't always put the patient first and respect their wishes and try and guide them or navigate them through this process. And I think that's what's pushed patients towards doing home births sometimes. And I think there's the perception and some legitimacy to the fact that home births are considered safe. And in low-risk patients who have no other significant risk factors, and generally the natural process of childbirth is safe. It's when things go wrong that's the problem. Home births may not have the resources necessary to deal with the complications. Yes, you can deal with things like shoulder dystocias, but you may not have the tools to do resuscitation. You don't have the ability to do a cesarean section. You don't have blood products or other medications or surgical interventions necessary that may help to prevent or prevent long-term injury or offset or protect a woman against these issues. Postpartum hemorrhage is one of the major risk factors for women. It comes down to who you trust. And I think that's the most important thing, that you've got to really trust your provider. I would love to say the best thing is to find an obstetrician you can trust, because a hospital and an institution that does truly have your best interest at heart offers you the balance of empowerment and autonomy with that safety net that's necessary when things go wrong. And if you can find that, that's the best. But I can't say that every obstetrician gives that. And I can't say that every midwife doesn't. You've got to use clinical judgment as to how to manage these patients. Because sometimes, after an hour of pushing, I know there's no way this baby's coming out, and she should be sectioned. And avoidance of emergency procedures, that catastrophic rushing back and having to save somebody's life on ER, that's what we want to avoid. We never want that. We want the process to be planned, and I want to be able to predict what's going to happen an hour or two from now, and what I do now will then help to offset that. Yeah. And that goes back to trust and trusting clinical judgment and finding a way that helps the patient feel like they're making that decision, that they're part of that decision, as well as using our knowledge and expertise and a system that gets that patient through there and doesn't needlessly steer them down the wrong road. We need to recognize that while we consider it normal that a patient has a BMI of 30 or 35 or whatever, because such a large percentage of patients are overweight or obese, that translates to a significant risk of pregnancy. And we need to weigh those risks. And looking at advancing maternal age and the fact that we're delaying having children until we are older increases the likelihood of having high blood pressure in pregnancy, of diabetes in pregnancy, of small for gestational age. All of these things increase the likelihood of some necessary intervention in the labor process.